Okay. Let's go on to case 10. Chief complaint, unconscious patient. History. The patient is a young appearing man who arrives by ambulance unconscious. He has no wallet and was found by people who were walking by. The patient was well dressed. So when you get a patient in the emergency room who's unconscious, what is the best step? What's the next step in the management of such a patient? Now, theoretically, you have to consider a long list of differential diagnoses when you're talking about a patient who's unconscious or a patient who's in a coma. However, when you're talking about the next step in the management of the patient, that management can either be diagnostic or it can be therapeutic. And any patient who comes in who is unconscious, the next step in the management of such a patient is simply your ABCs. You have to ensure airway, you have to ensure breathing, and you have to ensure the circulation or the cardiovascular status of this patient. So when this patient comes into the emergency room, your primary concern is not diagnosis, but is stabilization. This is a patient who is unconscious. This is a patient who may not be breathing. This is a patient who needs acute care. So before sending the patient for a CT scan on the boards, before sending a urine toxicology or a serum toxicology, or before doing a gastric lavage, you have to ensure airway, you have to ensure breathing, and you have to ensure circulation. How do you ensure airway? Any patient who comes in unconscious gets naloxone to ensure airway. Either naloxone, which is the antidote to opiate overdose, or intubation. One or the other. You have to ensure the airway and the breathing. What else do patients get when they come in acutely unconscious? They get thiamine and they get glucose. Thiamine and glucose. So the best initial step in the management of this patient, the first step in the management of such a patient is not CT scan of the head, not electrolytes, not toxicology, but rather it is naloxone, thiamine, glucose, or intubation. Airway, breathing, circulation. If the patient is hypotensive, what do you give the patient initially? Do you give the patient dopamine? Do you give the patient dobutamine? Do you give the patient norepinephrine? No. The initial management of hypotension is IV fluids. So you must ensure airway, you must ensure breathing, you must ensure circulation before you go searching for an etiology of this patient's unconscious state. So when this patient comes in, they get naloxone, they get thiamine, and they get glucose. You never give glucose before thiamine, because if you give glucose before thiamine, you can precipitate Wernicke's encephalopathy if the patient is an alcoholic, and that's a problem. So you always give naloxone, thiamine, glucose, naloxone, thiamine, and glucose. You ensure you secure an airway, you secure breathing, and you secure hemodynamically stable status with IV fluids and, if necessary, pressor agents like norepinephrine, dopamine, or dobutamine. Now, once you have secured the airway, once you have secured breathing and circulation, you can then search for a cause and work up this patient's coma-like state or this patient's unconsciousness. And what is the basic differential of unconsciousness or decreased consciousness? You think about structural lesions of the brain. Can an intracranial bleed cause a coma or unconsciousness? The answer is yes. Can a brain tumor cause unconsciousness? The answer is yes. Can a stroke cause unconsciousness? The answer is yes. So you consider structural lesions of the CNS. Are there infectious causes of unconsciousness? Yes. Always consider meningitis, encephalitis. Are there metabolic causes of coma? The answer is yes. Always consider hyponatremia, hypocalcemia, hypomagnesemia, drug overdose, so on. Liver disease, renal disease. And your physical exam will be focused on trying to determine what is the etiology of this patient's unconsciousness. So, if you go through your differential, if you're looking for a brain tumor, or you're looking for an intracranial bleed, what kind of things will you look for on history and physical? You may look for a history of progressive neurologic deficit. You may look for a history of hypertension consistent with a bleed or CVA. If you are looking for metabolic causes of the of an unconscious state, what will you look for in the history? You will look for a history of respiratory failure if you're considering hypoxia. Is there a history of drug abuse if you want to consider overdose as a cause? Is there any concomitant illness that can cause hypocalcemia, hyponatremia, hypomagnesemia that can account for it? And you will check your electrolytes. In a patient who is unconscious, in whom you are considering meningitis, encephalitis, what will you look for on physical exam? You will look for nuchal rigidity. You will look for Brzezinski, Koenig's, and Berdinski signs. Basically, when you flex the neck, does the knee come up? Does the head come up when you flex the knee? You will look for these signs. You will look, does the patient have fever? Does the patient have a white cell count? Does the patient appear septic or not septic? Based on the question. So when you have a patient who is unconscious, first you will address the life-saving maneuvers, A, B, and C. Airway, breathing, circulation. Then you will search for an etiology, which can be metabolic, electrolytes, hypoxia, evidence of liver disease, toxicologies in the serum and the urine, gastric lavage. You will look for structural causes. Does the patient have a focal neurologic exam consistent with the structural disease? You will look for infectious causes. Is there fever? Is there white count? Is there evidence on physical exam of meningitis or meningeal irritation? So let's look on physical exam. We have a 35, the temperature is 35.8 degrees, slightly hypotensive, respiratory rate of 8 to 10. Unconscious patient with good respiration, pupils were small but equal and reactive to light, and patient was able to withdraw all four extremities from painful stimuli. So the fact that the patient is able to withdraw all four of his extremities means that a focal structural lesion becomes a little less likely because there's no focal neurologic exam. If this patient, he has absent deep tendon reflexes, and he also has several bullae present on the thighs. Now, the final diagnosis in this case is barbiturate overdose or intoxication. And what is the physical sign that is associated with barbiturate overdose? The answer is bulla. Patients who are unconscious with bulla, unconsciousness with bulla, bulla and unconsciousness, bulla and unconsciousness equals barbiturate overdose. Equals barbiturate overdose. So what's the differential diagnosis? We said heroin, alcohol, barbiturate overdose, hypoglycemia, hyperglycemia, hepatic renal failure, hypoxemia, seizure, bleeding, or some sort of structural lesion. We're going to check the CBC, the electrolytes, the calcium, gastric lavage, CT of the head to rule out a bleed, and an ABG to rule out hypoxemia. And what do we find? We find capsules, and the rest is normal. Now, is there any specific antidote for barbiturate overdose? The answer is no. Treatment is supportive. We intubate, we hold, and we hope that they come out of it. We give them charcoal to inhibit. We give them charcoal to inhibit the absorption of the drug. Maybe several times. The diagnosis is made with gastric lavage. Now, if a patient had overdose with benzodiazepine, what would be the specific antidote? The answer is flumazenil. So benzodiazepine overdose gets flumazenil. Barbiturate overdose has no specific antidote, but is treated by inhibiting the absorption and supportive care. But again, when a patient comes in who is unconscious, you address airway, breathing, circulation. Then you look for an etiology. Airway is naloxone, thiamine, and glucose. Circulation is with IV fluids initially, and then pressors if needed. After you have addressed these acute issues, you search for an etiology, and you check toxicology, electrolytes, renal function, hepatic function. You do a CT scan of the head, an ABG like we've gone over. Let's go on to the next case. The final diagnosis will be barbiturate coma. Case 11. Chief complaint: progressive memory problems. The patient is a 64-year-old man without significant medical history who has developed the gradual onset of forgetfulness. He initially noted that he forgot where he had placed things and then found that he could not remember certain words. His wife was worried about his hearing since he kept asking her the same questions again and again. So most recently, he seemed to get lost on the way to the bathroom and had difficulty dressing himself. His wife states that he is not quite himself. So what is the most likely diagnosis in a 64-year-old man who presents with gradual onset of memory deficit? The most likely diagnosis is Alzheimer's disease. However, there are a number of things that you have to exclude, i.e., treatable causes of dementia, before you can make a diagnosis of Alzheimer's disease and before you can write off this gentleman's dementia by saying that he has Alzheimer's disease. Because after all, if he has depression and is demented, and you can treat his depression and improve his dementia, that is something that you'd want to do. So the basic algorithm is an elderly person who presents with progressive loss of memory. You must first exclude causes of dementia, medical causes of dementia, before you can make the diagnosis of exclusion, basically, of Alzheimer's disease. Well, what kind of things cause dementia? Hypothyroidism. So every patient who comes in with dementia has to be checked. The thyroid function studies have to be checked. Syphilis can give you dementia. So you must check an RPR or VDRL as a screening test. for syphilis. You check the B12, because that can give you dementia. There's something called normal pressure hydrocephalus. There are structural causes of dementia. Brain tumors can give you dementia. Normal pressure hydrocephalus can give you dementia. The triad for normal pressure hydrocephalus is dementia, ataxia, and urinary incontinence. Dementia, ataxia, and urinary incontinence. Renal disease can give you dementia. Liver disease can give you dementia. So a gentleman comes in with dementia, gradual onset of memory loss. You must exclude hypothyroidism. You must exclude hepatic disease. You must exclude renal disease. You must exclude syphilis. You must exclude B12 deficiency. You must exclude all of these things. You must do an MRI or CT scan of the head to exclude structural causes of his dementia. Multi-infarct dementia can cause dementia. Well, it's called multi-infarct dementia because it can cause dementia. And what's characteristic of multi-infarct dementia is that the dementia is worsened after every single cerebrovascular event. That is the classic step down level of cognitive function associated with multi-infarct dementia. Practically, it can be very, very difficult to differentiate between Alzheimer's disease and multi-infarct dementia. But classically, they will give you a step-down progression. CVA with worsening dementia, stable, until the next CVA, where the dementia gets worse, is stable, until the next CVA, where the dementia gets worse, it is stable until the next CVA. That is multi-infarct dementia. How do you treat normal pressure hydrocephalus? Again, normal pressure hydrocephalus is the triad of ataxia, urinary incontinence, and dementia. How do you treat it? You do a lumbar puncture. You drain a certain amount of cerebrospinal fluid. If the patient's symptoms improve with drainage of the normal pressure hydrocephalus, then you put in a shunt to drain and decompress the brain. And that way, improve the disease. So, we have a 64-year-old man who has progressive loss of memory, and let's look at his exam. Now, why is physical exam important in the workup of dementia? The reason why physical exam is important in the workup of dementia is as follows: is that we're talking about structural lesions, a chronic subdural hematoma, a frontal lobe tumor, that can cause dementia. It can cause dementia. However, it's very, very rare to have a structural anatomic cause of dementia without a focal neurologic exam. And generally, when we make a discovery of a structural or anatomic reason for the dementia, when you go back and you examine the patient, there is some subtle focal neurologic deficit. So if we look on our physical exam and there is no focal neurologic deficit, it speaks against a structural or anatomic cause of the dementia. So let's look at the physical exam. Normal vital signs, decrease in naming objects, decrease in calculations. None of the objects were remembered in 5 minutes. So he has a memory deficit. Now, the characteristic loss of cognitive function in Alzheimer's disease is loss of memory first, and then personality changes. Loss of memory first, and then personality changes. Meaning the patient will not be able to remember, and as the dementia becomes denser and denser and denser, and thicker and thicker and thicker, Then they will become agitated. Then they will hallucinate. Then they will be agitated and they will fight. They lose their memory, and then the personality changes come later. Pick's disease is the opposite. Pick's disease has personality changes first. Pick's disease has personality changes before the memory loss, which occurs later. Pick's disease has personality changes first and then memory loss. So on our physical exam, we have a gentleman with dementia who has no focal neurologic deficit and has primarily a memory loss without personality changes. This is characteristic of Alzheimer's disease. We cannot make the diagnosis of Alzheimer's disease until we exclude secondary causes of dementia like hypothyroidism, B12 deficiency, syphilis, hepatic disease, renal disease. And once we've excluded these diagnoses, then we can say that this patient most probably has Alzheimer's disease. How do we treat Alzheimer's disease? We give donepezil or Aricept. Now on the boards, if they give you Cognex, Exelon, Reminil, in the same question, you're going to answer donepezil because it's a Q daily dosing drug and it has the best side effect profile. Let's go on. The final diagnosis is Alzheimer's disease. Let's go on to the next case. Case 12. Chief complaint, headache. Patient is a 20-year-old woman with a severe headache. She describes a headache history that began when she was 14 years old. Headaches occur every 3 months and are very severe. She describes an alteration in vision that begins in the right field of vision and consists of bright flashing lights. She has just finished a very challenging year in college, and on coming home to her parents' house, she noted the recurrence of this headache accompanied by both visual symptoms as well as by nausea and vomiting. This headache is much worse than her previous headaches, and she has decided to get medical evaluation. She has recently started with birth control pills and has taken up smoking tobacco. So whenever you have a patient who presents with a headache, the first question you have to ask yourself is, very similar to a patient who presents with acute back pain, is this a neurologic emergency or is this a chronic headache or primary headache syndrome? Is there a secondary cause to this patient's headache? Or am I dealing with a primary headache syndrome? Now, what kind of alarm signs or accompanying factors make you think of a neurologic emergency or a secondary headache syndrome? Well, if in the question on the USMLE, the headache is sudden onset, and it's the worst headache that the patient has ever had in their life, then you think of what diagnosis? A subarachnoid hemorrhage. If a patient has fever with the headache, if a patient has decreased mental status with the headache, if a patient has a focal neurologic exam associated with a headache, then these are all signs that the headache may be a little bit more malignant and may be secondary to a cause, maybe secondary to a medical disease that it needs to be emergently treated rather than a primary headache disorder. So if there is fever, decreased mental status, nuchal rigidity, and headache, you think of what? Meningitis. if there is focal neurologic deficit associated with the headache of chronic onset, you have to think of a brain tumor. If a patient has worsening symptoms in the morning, has a post-tussive headache, the headache gets worse after they cough, and you have to think of brain tumor. If a patient has new onset of headache after the age of 40 years, it is less likely to be a primary headache disorder and more likely to be a structural problem. So when you look at the patient with headache, you have to ask yourself, is this a neurologic emergency that I have to deal with now? Or is this a chronic process that is primary and has to be treated but is not a neurologic emergency? So let's look at our history. She's a 20-year-old woman with a severe headache. She has a headache history. That implies a non-emergent cause of her headache. And those headaches began when she was 14 years old. She has headaches every 3 months. They're very severe. And before she has her headache, she has these alterations in her vision that consist of bright flashing lights. She's under a certain amount of stress, finished her freshman year in college, and her headache is recurring with the visual symptoms and is accompanied by nausea and vomiting. But her headaches have worsened. Now, why would you get an imaging study on this patient? Simply because even though she has a chronic headache history, and her headaches began when her puberty began, which implies that she has a migraine, and she has an aura before the onset of the headache with bright flashing lights, which also implies migraine. She has nausea and vomiting. But the fact that her headaches are worsening requires you to go and actually do an imaging study, even though you have classic signs of a migraine headache. The fact that she recently started birth control pills and has taken up smoking are also clinical clues that this patient has a migraine headache. Now, what other primary headache disorders are there? Well, we talk about migraine headaches. We talk about cluster headaches. We talk about tension headaches. Those are the three major categories of primary headache disorder. And how do we differentiate between a cluster headache and a migraine headache and a tension headache? Simply on the history. Well, migraine headaches can be bilateral, can be unilateral. Generally are accompanied by an aura of some sort, if it is migraine with aura, but not necessarily. Usually are throbbing in nature. Cluster headaches are unilateral, always, associated with redness of the eye, rhinorrhea. Now, what about the temporal aspect or the onset of the headache helps to differentiate between cluster headache and migraine? Well, cluster headaches occur in clusters. Patients may have 4 or 5 headaches for a number of days, for a month or 2, and then have remission, or a hiatus without headache, and then have more clusters. There is a male predominance in cluster headache. But in addition to the clustering of it, cluster headache is different than migraine in one other way. Migraines will tend to peak over a period of hours, even days. Patients will feel the headache coming on at 9 o'clock in the morning, and the headache may not peak until 10 o'clock at night. And they will last for hours. Patients will want to go into a dark room, lie down, close the shades, stay very, very, very still, be very sensitive to light, be very sensitive to sound, and their headache will get worse over hours and hours and hours and peak over many hours. In cluster headache, the peak occurs within minutes. The peak will come acutely, will occur within minutes, and then will go away. Will peak within minutes, and then will go away. So when you have a patient with headache, you want to know if this is an emergency. Once you determine that it's not an emergency, you want to differentiate between migraine cluster, and tension. And how do we differentiate? We look for an aura. We look for how long it takes for the headache to peak. We look for associated symptoms like scintillating scotomas, like rhinorrhea, like Horner syndrome, which is ptosis, meiosis, and anhidrosis in patients with cluster headache, with redness of the eye as well. Now, how do we treat headaches? Well, let's get to tension headaches before we go on to treatment. Tension headaches are usually bilateral, described as a band across the head. A band across the head, bilateral headaches, usually associated with anxiety. Now, how do we treat migraine headaches? How do we treat cluster headaches? And how do we treat tension headaches? Let's start with tension headaches because they're the easiest. Patients with tension headaches simply get analgesia, analgesics, Tylenol, NSAIDs, so on. Patients with cluster headache and migraine headache, since both of these are vascular headaches, we divide our treatment into acute or abortive treatment and prophylactic or preventative treatment. Now, how do we treat vascular headaches like migraine and cluster acutely? We give ergot alkaloids, ergotamine, and we also give sumatriptan. Ergotamine and sumatriptan. Now, what are relative contraindications to these medications? Well, if you think about the pathophysiology of vascular headaches, it's thought that migraine headaches and cluster headaches are secondary to what? Vasodilation of the arteries supplying the head. So we give ergotamine and we give sumatriptan because they are vasoconstrictors. And if you think about a patient who has coronary artery disease or a patient who has peripheral vascular disease, who may have lesions in their arteries, if you vasoconstrict their internal carotid with the sumatriptan, you may also vasoconstrict their left main or the left anterior descending artery. You may also vasoconstrict the dorsalis pedis artery, and you may induce ischemia. So patients who have coronary artery disease or even risk factors for coronary artery disease, you have to have a certain degree of caution when you give these vasoconstrictive medications like sumatriptan and ergotamine. Sumatriptan and ergotamine. Additionally, patients who are pregnant, ergotamine can actually induce labor. So you have to be careful in pregnancy, and you have to be careful when there's evidence of atherosclerotic disease in general. So for abortive treatment, we give ergot alkaloids and we give sumatriptan. For prophylaxis, we give beta blockers, calcium channel blockers, amitriptyline. You can give SSRIs. You can give carbamazepine, which is an anticonvulsant. You can also give for cluster headaches, but not for migraine headaches, prednisone to prophylax for chronic headaches, the primary headache disorders. So again, there is acute abortive treatment for the vascular headaches and prophylactic treatment. In addition to which, cluster headaches, you can give 100% oxygen. So be aware that on the boards, on the USMLE, for cluster headaches, always consider abortive treatment. You can treat cluster headaches more or less like migraine. But the answer that you're looking for in terms of acute treatment is 100% oxygen. And if you would have to choose between 100% O2 and sumatriptan for cluster headaches, you would go with the 100% O2. You would go with the 100% O2. Again, in headache, the best question, the most important question to ask is this a neurologic emergency? You answer that question by looking at the history and the physical exam. If it is not a neurologic emergency, you consider migraine versus cluster versus tension headache. You treat migraine prophylactically with beta blockers, with calcium channel blockers. You treat cluster headache the same way, abortive treatment with sumatriptan or ergoalkaloids, and tension headaches get treated with analgesics. Now, how do you make a choice? What if on the USMLE they give you a question, a patient with migraine headaches who's having migraine headaches more than twice a week, and you want to give this patient prophylaxis? But what if they give you an answer that one answer choice is verapamil, which you can use for prophylaxis. Another answer choice is a beta blocker, which you can use for prophylaxis. And another answer choice is amitriptyline. They give you all three choices. How are you going to choose one over the other? So the answer is you're going to look at the comorbidity. So, for example, if this young lady who's a 20-year-old woman comes with a severe headache, and she has a migraine, and she has a family history, and you want to give her prophylaxis, but she also has a history of asthma, you would not give her the beta blocker, but you would give her the calcium channel blocker or the amitriptyline. If a patient comes with a history of coronary artery disease, and a history of decreased LV function, and heart failure, you would not give the verapamil for prophylaxis because that would actually increase his mortality in terms of his heart failure, but you would give him the beta blocker because that would increase or decrease his mortality in terms of his decreased LV function. So if you're stuck between a calcium channel blocker and a beta blocker, and you're stuck between amitriptyline and a calcium channel blocker or a beta blocker, look at the comorbidities. It may give you a hint. A patient who comes with hypertension, and they give you verapamil and they give you a beta blocker. Why would you go with the beta blocker? Only hypertension. Why would you go with the beta blocker, not the calcium channel blocker? Because first-line treatment for hypertension is beta blocker and hydrochlorothiazide, because those are the only two medications that have been shown in randomized, double-blinded clinical trials to decrease mortality in the treatment of hypertension. So if a patient has isolated hypertension with migraine headaches and you want to prophylax, you will look at the comorbidities and you will make a decision based upon the comorbid conditions. So on physical exam, she's non-focal. So our differential diagnosis is a classic migraine, a common migraine, seizure, brain tumor, arteriovenous malformation. Again, brain tumor becomes a lot less likely because there's non-focal physical exam. She's not complaining of focal weakness. We get the MRI because her symptoms are worsening and we have to exclude a structural cause to her worsening headaches. And the MRI is negative. Patient has a history consistent with classic migraine, and the final diagnosis is migraine. Let's take a break.